EUROASPIRE surveys should be seen as part of a more comprehensive program of preventive cardiology by the ESC. Surveys are kind of an auditing of how well these guidelines are implemented in daily practice. The fifth survey that we just finished dealing with the implementation of the guidelines that came out in 2016. The last EUROASPIRE V was done in 27 countries all over Europe, but also some of them outside of Europe. Altogether, 131 centers participated in these 27 countries with patients with well-documented coronary heart disease. These were all patients, consecutive series of patients who were hospitalized because either an acute coronary syndrome, an elective PTCA, or an elective CABG. So well-documented coronary patients. And then we invited these patients for an interview, and 56% indeed participated in that interview. So I think an important issue to remember is that all the data that we are collecting are done with standardized methods by trained technicians. The laboratory measurements, for instance, regarding lipids, are all analyzed in one laboratory in Helsinki, a central laboratory. So we are really trying to have, in terms of methods, the quality of our survey as high as possible. So then we were looking, of course, in the first place at the proportion of these patients on target, meaning an LDL cholesterol of less than 1.8 millimole per liter or 70 milligrams per deciliter. 1 in 3 was indeed at goal. 2 out of 3 were not at goal at that moment. But then in terms of drug therapy, 86% of these patients were taking lipid-lowering drugs, and despite that, only 1 in 3 was at goal. So that is a first issue that we should address. What about the dosage, and what about the kind of statin? 60% of all those on lipid-lowering drugs were on high-intensity statins, and despite that, only 1 in 3 was at goal. So that is the point that we have to make, I think, towards our clinicians nowadays, that first of all, that all of our patients should be on a high-intensity statin, and then combination therapy should be considered, where statins with ezetimibe will make a better chance of reaching the goal that we have not yet reached at this moment. But besides that, we have now new families of lipid-lowering drugs also available, the PCSK9 inhibitors, especially in those patients who, despite high-intensity statins, combinations with ezetimibe, who remain with an LDL above 2.5 or above 100 milligrams per deciliter, and that is still 1/4 of our patients. In our experience in EUROASPIRE, that 20% of our patients who were discharged from hospital on a high-intensity statin were, at 1 year when we saw them, were either on a moderate intensity or had stopped completely the statins. Well, I agree there are some patients who are statin intolerant, but that is not that large proportion, that is not 20% of our patients. And then on the other hand, we have patients who are discharged from hospital on a moderate intensity and who remain on that moderate intensity. And there again, there is a certain, what we are calling physician inertia, to really to get to a higher dosage, to more combinations, to reach the goals. I think that is a message to the clinicians, to follow these patients.